Now, as we have finished our hands-on evaluation of the patient, we normally in our setting go offline and see the images and loops on a computer program. But we can also, of course, measure with the machine, and we start again with the parasternal long axis view. And what you can do is, all the time you have to stop your image, because then you actually can measure. And the first structures we want to see are the aortic structures. And we go to measure, we already played around a bit, and we can use a measurement of the ascending aorta, and we measure where we see it best, and we measure from outer to inner edge. It's in the range of 30 millimeters, 29, 20, 30, 31 probably. We can save it as well. We have a normal dimension of the aorta. When I continue the measurements, I can simply show you for demonstration purposes. Here you would measure the aortic root, the sinotubular junction you can measure, and of course the ascending aorta here was a bit generous. You can measure several times wherever you see it optimally. You can save the image, and then we move to the next image, because what we additionally want to measure, of course, is, and here we're already too far, is the left ventricular wall thickness. And here we need an optimal diastolic image, and it's not easy to scan this patient. So the mitral valve should be closed, and it should be really in end diastole. And we can try to measure the interventricular septum here, even though it's really hard. I think those are right ventricular structures. I would measure probably here, where you have really a thick septum, and it's in the range of, I would say, 22, 23, 24 millimeters, which was also what we got on the MRI. So here we have a limitation in our measurements, because it's simply harder to see and harder to differentiate, because the patient was not easy to scan. The inner ventricular diameter we can try, and I would say approximately here it will be, but it's more a guessing game. So here I would be very careful to measure the myocardial thicknesses and the inner diameters, and here you can measure it. What you see here in the measurements over here, the ejection fraction with Teichholz and fractional shortening, please forget it immediately. Those we do not measure anymore. So it's simply about the measurements of the thicknesses of the walls and the myocardial mass and the RVT. Optimally, we measure at the area where the mitral valve is closed. In this case, with our hypertrophic cardiomyopathy patient, it's also where we see it best simply. So where we see it best, where the myocardial is the thickest, we have to measure. And what we see here is the LVOT and this caudal Zambi, also described before. Now we continue, because one more thing we have to visualize is the LVOT, and that we will do here. So we have to find an optimally mid-systolic measurement of the LVOT, and here is most likely the best way to measure. And we have here the LVOT diameter, and we measure it approximately 1 to 2 millimeters away from the aortic valve, and then we do a little bit more, so it's in the range of 22, 23 millimeters probably. So this is a difficult measurement, but we need it for aortic stenosis. And if you're not sure and you have an error in measurement, you go back and measure the LVOT again. Here you can also measure the LVOT, so we have two images, so it's rather okay. We do not see a relevant SAM. This is zoomed, so we do not see a relevant SAM, so really the chorda, the elongated chorda, move inwards the LVOT. Color Doppler again, but we continue with our TR measurements, which we simply cannot in this case, so we do not measure it. And then we move forward and measure the pulmonary acceleration time. This is a time interval which gives us a lot of information about pulmonary pressures, and when it's above 100, 120 depending on age, it's most likely that there is no pulmonary hypertension present. As the signals are not optimal and the measurement is not easy, I measure it always several times if I'm not sure, to see the mean pulmonary acceleration time, and all the measurements were above 100, so most likely there is no relevant pulmonary hypertension present. We can do it again, and we can also continue with our evaluation, and here we see there is no pericardial. This is the descending aorta, this is lung tissue, this is the pericardium. There is no free fluid, so it's not entirely black. In the short axis we do see the aortic valve over here. It's probably there's no relevant pathology, but it's very hard to see. So we move on to the short axis view of the pulmonary outflow tract. It measures the RVOT and the RVOT max and the gradients, but both measurements, they are not optimal, so I wouldn't use them. If the automatic measurements work, then they're really good to use. And here it's also harder to see the signal over here. I would not adjust the gain too much, because then it leads to overestimation, underestimation. But so we have several signals where we think it's always around 100, a little bit more milliseconds. Then we continue, and here we are in the short axis view, and we can try to measure the LV dimensions again, but here it's really hard to see, so we move on. Maybe we have a more optimal image. Let's try here at the papillary muscle level, but it's also very hard to see. So let me just see here, it's closed, and here's the maximally dilated ventricle, and let's just try with a normal distance measurement. Here is most likely the right ventricle. I would go until here. So again, we're in the similar range, but in this case, it's better to measure with contrast or, of course, an MRI, because the image quality is simply not optimal.